Okay, guys, you would have seen that normally a disease has a predilection to attack a particular organ. But SL is such a nasty disorder that it is attacking almost all organs in the body. It's literally like the disease wakes up in the morning, spins a wheel, and says, okay, today I'm going to attack the heart. So there's going to be pericarditis and chest pain. Another day, it will attack the lungs. So they can be pleuritis. It can be attacking the brain. So they can be headache and seizures. It can attack the skin. So that can contribute to photosensitivity. So there's like a huge myriad range of manifestations that we see in systemic lupus erythematosus, and that is why there's a fixed set of diagnostic criteria that I'll be teaching you subsequently so that we can arrive at a proper conclusion or diagnosis of this condition. Now, all of you would have listened to that song Calm Down by Selena Gomez. This is a Twitter handle snapshot of Selena Gomez. She's a pop singer from America, and she was diagnosed with SLE when her kidneys failed. She developed lupus nephritis. I mean, though she's living in America, which is supposed to be having like the highest level of healthcare capability for diagnosing any particular disorder, but the diagnosis of her was made so late that she almost died because of renal failure. Luckily, her friend came to her rescue. She agreed to donate a kidney for her, and being rich, she was able to afford a kidney transplantation. And then subsequently, being a survivor, she was made the president of Lupus Foundation to increase the awareness of lupus in women, because the disease shows a predilection to involve female patients only. And this was just an appreciation post on Twitter where she was thanking the healthcare staff regarding the support that she got while she was hospitalized. Now, as far as this topic is concerned, I would like to highlight that very characteristic manifestation that we see in this patient is this malar rash. And there was a question, I think this was FMG exam. They said all are features of SLE except, and one of the options is malar, was given as malar flush. Now, that was the answer to the question, because what we get in this condition is a malar rash that would be present on the cheeks, present on the bridge of the nose, and usually, does not involve the nasolabial folds. I'll talk about the technical aspects of this malar rash subsequently also. But at this, I just want to bring to your attention that sometimes, in those MCQs, he just plays with these English words or terminologies which are to be kept in mind, that malar flush is a feature that we see with mitral stenosis, whereas malar rash is a feature that we see with respect to systemic lupus erythematosus, and more about this malar rash subsequently. Now, this disease from the pathogenesis perspective is an example of type 3 hypersensitivity reaction, that's immune complex deposition, and then this causes autophagy, that damage to self, and netosis. Netosis, you are aware from pathology, is neutrophil extracellular traps. So for describing this, I can say, like, if you watch Spider-Man, Spider-Man, whenever he sees bad guys, he'll just do like this, and there would be a mesh or like a web being released that will trap the bad guys. Similarly, neutrophil is spinning a web to trap the bad guys. That's what is called as neutrophil extracellular traps. But in patients of SLE, this neutrophil extracellular traps are causing damage to blood vessels of the self, especially the blood vessels of the kidney tend to get involved. So we get lupus nephritis. So netosis is a part of the pathogenesis process of SLE. And this was again a question in the exam, that which autoimmune disorder exhibits netosis. And there were a couple of clinical manifestations also discussed that were, in sync with whatever is present in SLE. So those clinical features I'll discuss subsequently, but I just wanted to highlight that there is an increased autophagy and increased netosis where there is damage to cell blood vessels and self tissues. As far as gender is concerned, female patients will outnumber male patients by a ratio of about 6:1. The exact ratio would be 5.5 to 6.5. That is for all female patients. That's, like I said, 6 patients. Female for 1 male patient who would be diagnosed. So this tells us also that probably X chromosome has something to do with the pathogenesis of the disorder, and therefore we found that there is a gene that is involved here on the X chromosome. I mean, genetics is the in thing always, so it's always a good idea to remember it. So the gene that is present here is called as TREX1 gene. And then what I want to bring to your attention is that Klinefelter syndrome is a male patient, but this guy, because he's having 2 X chromosomes, that means this guy's SLE severity will be much more as compared to what is going to occur in a male with SLE. Let's compare 2 patients. One is a male patient with SLE. Second is a Klinefelter who's also male with SLE. But you can understand a male is XY and Klinefelter is XXY. So more number of genes, more severity of manifestations would be seen in Klinefelter as compared to a male patient who's suffering from systemic lupus erythematosus. Now, this disease shows a tendency to involve multiple organs. One of them is going to be the skin. So you can have a malar rash developing, which is very peculiar in a sense that it involves the nose, it involves the cheeks, but usually tends to involve, it can involve the earlobes also. The sun exposed parts can be involved, even sometimes even the cheek area can be involved. And most of the time photosensitivity can be associated, that when these patients will go out in the sun, it will literally contribute to development of a first degree skin burn. Now, why have I shown this image once again to use to bring to your attention that malar rash is not the most, skin involvement is not the most common body system involved in patients of SLE. The question in the paper said, what is the most common body system involved in SLE? And the answer is not dermatological. It is musculoskeletal. Most patients would be coming to you with vague body pains and joint pain. So it's musculoskeletal system overall, that is joint pain and arthralgia would be the usual description given for patients of SLE initially. And then along with this, like this lady is always feeling fever, there would be constitutional symptoms present. She might be having low-grade fever, and because of that, she might be even worked up for tuberculosis, but that workup will turn out to be negative. It is the autoimmune panel which will turn out to be positive in this case. Now, the set of diagnostic criteria that I'll be describing for this condition will be two. One is SLICC criteria, and the second one is 2019 EULAR ACR criteria. So I'll show you the involvement or the classification subsequently, that is EULAR or ACR. But at the moment, like I'm saying, that maximum value is assigned to which body system in this EULAR criteria, that's the European Union criteria or the American College of Rheumat, then it is the kidney involvement which is given maximum weightage. You see, I said two different things. One, I said the commonest part of the body that gets involved is musculoskeletal, but then which is more specific for the disease, then more specific for the disease is the kidney involvement. That's mainly going to be development of lupus nephritis. And this is again a very famous question of your exam, that what is the light microscopy finding of lupus nephritis? That is in the form of wire loop lesions. In fact, he can even go more deeper into asking you regarding the various classes of these lupus nephritis that we study. And most of the time it is like class 3 and class 4, which are tending to be given the maximum weightage in the diagnostic criteria. Then in this EULAR ACR criteria, there are a total of more than 10 points. Like there's a scoring system that we have created, because as I said, now the disease is having so many manifestations that we create a scoring system, and if the patient gets more than 10 marks on the scoring system, that is when we can diagnose SLE. And these 10 points are spread over multiple clinical domains and immunological domains. Let me just show them to you, though the table will be discussed subsequently again as well. You see the antibodies, because these names of antibodies at the moment might be sounding alien too. When I speak about them subsequently, then you will become familiar. That is, like, we can get antiphospholipid antibodies. They are the ones which could be associated with like bad obstetric history that can be seen in these patients. Then the complement system is activated. Then we have these specific antibodies, anti-Smith antibody, double-stranded DNA antibodies. They help in increasing our diagnostic capability. So you can see that if this antibody is present, then we will be taking like 6 marks. Similarly, you can see neuropsychiatric manifestations can occur, hematological or constitutional symptoms can be present. So we have to add up these numbers overall, and when we add the numbers, if the score turns out to be more than 10, it is SLE, and like it is spread over total of 7 clinical domains. I've shown you only 3 at the moment, that is constitutional, hemat, and neuropsychiatric. So the remaining will be discussed subsequently. And then there are 3 immunological domains which are to be considered, and based on the scoring pattern, final score has to be obtained. Then additional aspect which he can ask you is, what is the obligatory entry level criteria for saying it is SLE? We cannot say SLE, like even if all these things that I was showing you are present, but if AN is negative, I cannot call it SLE. So obligatory entry level criteria for diagnosis is anti-nuclear antibody, and most of the time the report will say like anti-nuclear antibody is positive at more than 1:80 dilution titer on human epithelial cells. So most of the time he's gonna mention an immunofluorescence report here as well with respect to anti-nuclear antibody, which is the most sensitive antibody or is a screening test for diagnosis of this condition. And now what I will focus before you would be to explain first the SLICC criteria, and after the SLICC criteria, then the EULAR and the ACR scoring pattern that is mentioned on the following clinical domains and immunological domains will also be discussed. Now the mnemonic I can request you to remember for these criteria is called as sonar, where alphabet S will be used multiple times. So the first one on the agenda would be to remember synovitis. So we do not have arthritis. It is a synovitis that would be present. So it's a non-erosive damage to the joints. Most of the time, the joints involved are at least 2 or more than 2 joints. And then if he says which joints are involved, it's usually the small joints of the hand. It's like tenderness over the small joints of the hand. But make no mistake, even large joints like knee can be involved. That's one of the weight-bearing joints. So when you read this tenderness over the small joints, now the thought process of ours can be that is it a question of rheumatoid arthritis? But in rheumatoid arthritis, it is a arthritis after all. No, so there's going to be deformity. There's going to be redness and inflammation of the joints, and deformities will ensure. Whereas with respect to SLE, it's mainly a synovitis. So in a young female, you may not be seeing any deformities developing in these patients. And overall, like I said, there would be initially a soft tissue swelling and difficulty in ambulation for these patients. That is the first S, synovitis. And then along with this, the next S to be remembered is serositis. When I talk about the serositis component, then 2 important things are to be remembered, that the disease is attacking lungs or it could be attacking the heart. And if it's going to attack the lungs, then the manifestations with respect to the lungs can be development of pleuritis, which will cause a pleural rub. And if it's going to be pericarditis, it will cause a pericardial rub. Now, how do you differentiate between the two? You will ask the patient to hold breath. And if on holding breath the sound is persisting, then it cannot be coming from lungs. It has to be coming from the heart. So one, I just wanted to bring to your attention that if a SLE patient is having chest pain and we are auscultating a friction rub, it can either be a pleural rub, it can be a pericardial friction rub. The best way to differentiate between the two is breath holding. Like I'm writing pericardial friction rub, the sound is gonna persist in spite of the fact that you requested the patient to count in the mind like 1, 2, 3, 4, 5, and you said just hold your breath for like a short duration as long as you can. And if the sound persists in spite of breath holding, then it's gonna be pericarditis. But if the sound is gonna disappear, then obviously it was and another differentiation is like pleural rub is gonna be over the lungs and pericardial rub is on over the heart. But then because of the scratchy sound that was coming, I wanted to be sure. So that is why I said like we can differentiate between the two. And if you are in doubt, even then you can anyway do a ECG, and the ECG will be showing a ST elevation for pericarditis, but that would not be the case for pleuritis. Then comes the least common lung involvement for SLE. This is a very important question repeated again and again in especially FMG exam, that is shrinking lung syndrome. So I'll talk about what they have asked in NEET PG also in a while, but I'm just handling those easy ones that came in the paper. Like one was like Maller, which is not a feature of SLE, Maller flush. And there was what is the least common lung involvement in patients of SLE, that is called as shrinking lung syndrome. And contrast this with like if he says what's the manifestation of the heart with this particular condition, then this term that I'm writing is read by you very well in pathology. That would be called as Liebman-Sachs endocarditis. Because of this Liebman-Sachs endocarditis, he can also ask you which heart valve is the one that is usually involved. Then by default, because mitral valve in our body operates at the highest pressure gradient, so mitral valve is the one which is most liable to be involved in Liebman-Sachs endocarditis. But make no mistake, the disease can affect the myocarditis. If it's going to go deeper, it can affect the conduction system of the heart, so they can be endocarditis. And the bad news is exerted atherosclerosis can occur. That can explain why patients of SLE tend to have an enhanced cardiovascular mortality. Most patients of SLE after 45 years of age can suffer from increased incidence of like cardiovascular death. So at the moment, alphabet S has come 2 times in the discussion. One is for the synovitis component and the second is for the serositis component. Now the alphabet S will come into discussion the 3rd time with respect to the skin. When I say skin involvement, he might write it as SCLE, that is subacute cutaneous lupus erythematosus, where 2 things would be described: photosensitivity and malar rash. And this malar rash is having always a butterfly configuration. So that's why like this, most of the time the examiner might be helping you in the exam by saying the word butterfly rash. Now, the question for you guys is that which antibody in SLE causes photosensitivity, especially because this is a topic that you would have read in pathology also. So which antibody in SLE contributes to photosensitivity? Yes, guys, if you can answer that without looking at notes, that's great. Otherwise, anyway, the notes would be incorporating this. But this I expected you guys to be familiar with because of the interdisciplinary effect. And anti-Ro antibody, you can remember it like a rolane wali antibody ki dhoop mein gaye ro diye. If you see in India, it's going to be so hot, like 50 degrees Celsius. You stand in the sun, you literally feel your skin is burning. But when you come out in the shade, you are okay, na? Here, the person will come out of the sun into the shade, and then the person will be saying, like, you see, my skin is literally like there's literally, like, a first degree burn. You see, you making maybe tea or coffee for yourself, and accidentally your hand touches the hot plate, you can get a burn. That's gonna hurt terribly. In this patient, standing in the sunlight for a few minutes will cause the skin to hurt so bad. Again, to what I was describing, like your hand has touched accidentally a hot plate, and the antibody which is responsible for this, जो patient को रुला देगी, उसका नाम है anti-Rho antibody. The alternative name for this is anti-SSA antibody, and the antibody will come up in our discussion once again as well. But at the moment, I just wanted you to remember this name, anti-Rho antibody for photosensitivity. Then you could be having a chronic cutaneous lupus erythematosus. So it is SCLE and CCLE. That is chronic cutaneous lupus erythematosus, where they can be discoid lupus or they can be paniculitis. Paniculitis means involvement of the fat. So antibodies are attacking fat also. So they could be like subcutaneous tenderness that can be elicited. And for discoid lupus, what I want to bring to your attention is that there would be disc-like rash present. This disc-like rash in the periphery will be having hyperpigmentation, and in the center part there would be presence of hypopigmentation. Now, because of the hyperpigmentation in the periphery and hypopigmentation in the central part, that is why like the word given is disc, and this hyperpigmentation, especially fair people, will look very, very outrageous, because normally like we have a uniform texture of our skin, but here these are circular lesions with hyperpigmentation in the periphery, hypopigmentation in the middle, and along with the hypopigmentation in the middle, what you also have is development or damage to the adnexa, like the sweat glands and the sebaceous glands are destroyed. Like normally, if you check the skin, like you'll see derma people using a magnifying glass. So if you come close to the skin of a normal person, you can see chota pores of like sweat glands and sebaceous glands. But this disease can attack those sweat glands and sebaceous glands. The adnexa can be damaged. And because of the damage to the adnexa, damage to the sweat glands and the sebaceous glands of these patients, that is why, like I said, that this would be having a presence of atrophic scarring. When I say the word atrophic scarring, it means that this is, imagine such a nasty autoimmune disorder, jo khud ke, it is attacking self, sweat glands and sebaceous glands. Then there can be aphthous ulcers developing in these patients also. Oral or nasal ulcers can be present, especially oral. Aphthous ulcers can occur in like you and me related to stress also. What I'm saying next is what I just want you to listen and note down. I mean, once in maybe 2 years, 3 years, even you and me can have aphthous ulcer inside of the lip, or maybe in the cheek area, inside of the cheek area, where like the spicy food is gonna hurt, and like for a few days we might not be able to feel comfortable. Then gradually the ulcer will disappear on its own. So stress can contribute to development of aphthous ulcers in normal people. Then even in the literature of inflammatory bowel disease, that is Crohn's and ulcerative colitis, I've spoken regarding presence of aphthous ulcers. Then another disorder where we get presence of aphthous ulcers and will be discussed subsequently, rheumatoid, is Behçet's disease. Behçet's disease involves aphthous ulcers, agreed. And what is the site of these aphthous ulcers would be, one is the oral cavity. But the additional thing that would be given, and why am I deviating into this, is because there was a question in the exam which said female patient, and then he said like she's always sick, and constitutional symptoms were described, and then he said aphthous ulcers. But he said that these aphthous ulcers are like crops of aphthous ulcers present in the oral cavity, like 2 or 3 are always in the mouth, and when these will heal, then the new ones will develop. So it's like crops of aphthous ulcers were described. And then he said the aphthous ulcers are involving the vulva also. So in SLE we do not have aphthous ulcers. That's the point, guys. Aphthous ulcers are present in SLE, but they do not involve the genitals. If genital involvement is given, then you have to think in terms of Behçet's disease, which is discussed subsequently in the rheumatoid section only. But I have introduced this at this moment to sensitize you to the fact that Behçet's disease will be having aphthous ulceration, and this aphthous ulceration will be involving the genitalia. Now, can Behçet's disease cause involvement of male patients? And if yes, then where will be the ulcers present on the genitalia? Then this is an important point to be remembered, which is very frequently asked in the exam. That is why I'm deviating from the topic of SLE into Behçet's, to say that the aphthous ulcers in these patients would be seen on the scrotum. Normally, like we see ulcers on the genitalia with an STD, but I'm teaching you scrotal ulcers, which is not a very routine thing to happen. So in Behçet's disease, we get genital ulcers, but that's scrotal ulcers. In female, it would be vulva, and then in the male patient also, like the oral aphthous ulcers would anyway be present. So I've just drawn a list of like conditions where we can be having aphthous ulceration. It could be stress, it could be IBD, it could be Behçet's, and obviously the topic of interest, that is SLE. Those are like conditions where aphthous ulcers can be present, 4 at the moment. Now I'll handle 2 image-based questions. One is this rash that can be seen in SLE that can mimic the rash of psoriasis also. And the second is more classical. That is what I was saying initially. That was discoid lupus erythematosus, where in the periphery there's like a hyperpigmentation. In the central part there is like a hypopigmentation present, and there is like loss of sweat glands and sebaceous glands. And this would be an extensive rash. Like this time I've shown a male patient having manifestations of discoid lupus erythematosus, that is chronic cutaneous lupus erythematosus. Then there can be loss of hair, that's non-scarring alopecia. So the mnemonic that is being discussed at the moment is sonar, just to keep the rhythm going. And sonar, alphabet S was being discussed 3 times. That was synovium. Then subsequent to the synovium, I'll just toggle the slides once again. Then I mentioned regarding serositis. This was a 2x2 table, heart and lung involvement. Then we spoke regarding skin involvement. O is for oral ulcers. And now we are on the N component, that is non-scarring alopecia. And alphabet N will also be used 2 times, one for non-scarring alopecia and second is neurological manifestations. Here a word of caution is that when I was describing the skin involvement, I was saying atrophic scarring, but for the hair I'm saying non-scarring alopecia. So take a distinction between the two. One is for the hair, it is non-scarring alopecia, and for the adnexa, it is going to be atrophic scarring. The neurological manifestations in this disease can be crazy. I mean, at this juncture, I can say that you can very well imagine what Selena Gomez would have gone through. I mean, she would have been headaches. She would be having these manifestations of neuropsychiatric profile that I'll explain to you. For this, she would have gone to a neurologist. Then she would have gone to a psychiatrist. Then she was losing hair, so she would be going to a derma person. Then because she would be having lung involvement, she'll be going to a pulmonologist. For a heart problem, she was going to a cardiologist. And none of these super specialists were talking to each other. So her diagnosis was missed till her kidneys got involved and she went up into lupus nephritis. You see, too much of super specialization also causes a problem, because if the same physician was seeing her on repeated basis when she was coming with these multiple complaints, then he would have tried to figure out, okay, what is causing so many manifestations in the same patient with different body systems getting involved. But because she was like going to different specialists, that is why the diagnosis in her case was made at a time when she was already having kidney damage so severe that she had to undergo a kidney transplantation. So at the moment, one, I wanted to bring to your attention that lupus is a nasty disorder that can cause nephritis. It can even cause cerebritis, and that cerebritis will explain why headaches, migraine-like headaches, and even because of the cerebral edema component, there can be even development of seizures. I mean, why am I saying seizures is because that can be explained with the cerebral edema component. Then there can be spinal cord involvement, myelopathy, cranial nerves involvement can occur. Any one of the cranial nerves can be involved, and you could even have neuropsychiatric manifestations. For these neuropsychiatric manifestations, he will then go into which antibody is responsible. So gradually, I'm building up your strength for the immunological domain, because earlier I mentioned an antibody with the name of anti-Rho, the Ronalin antibody for photosensitivity, and now mentioning an antibody with the name of anti-ribosomal P. While I'm writing it, I'm very sure you would have never seen anything like this in any other, discussion, antibody causing neuropsychiatric manifestations. I mean, that was the language of the question, that which antibody in SLE causes neuropsychiatric manifestations, and the answer is right in front of you. Anti-ribosomal P antibody contributes to development depression and even psychosis to develop in these patients. So the bad news about the disease is like multiple systems are getting involved one after the other, and you can very well understand if the immune system turns against your skin also, and heart also, and lung also, and the patient is always sick and always having causational symptoms, one is bound to suffer from depression. Now we are done with the N component. We come to the alphabet A, that is, there would be an autoimmune hemolytic anemia. If the question says what is the most common type of anemia that is seen in SLE, there are 2 separate questions. One is which of the following is a diagnostic criteria, then it is autoimmune hemolytic anemia. But then it says what is the type of anemia that is seen in SLE, then your answer would be given as anemia of chronic disease, because this is a chronic disorder, and anemia of chronic disease would result in development of normocytic, normochromic anemia. So one, if he says what is the most common type of anemia in SLE, then answer is given as anemia of chronic disease. But then you have to understand anemia of chronic disease would be seen seen in multiple disorders. Na? By anemia chronic disease would be seen in inflammatory bowel disease also. So that is not a diagnostic criteria. The diagnostic criteria is that antibodies in this condition are attacking self red blood cells, and that is why it can be written in questions as Coombs positive hemolytic anemia. The antibodies here can damage the white blood cells, so leukopenia, lymphopenia. That is why infections are common in patients of SLE, because the immune system is turning, the antibodies are turning against self-immune system. You can see due to destruction of the RBCs, these patients would be having a drop in hemoglobin, and therefore you would be evaluating this anemic patient's peripheral smear also. Now, traditionally, when you evaluate peripheral smear of a patient of microcytic hypochromic anemia due to iron deficiency, you usually see like microcytosis, hypochromia, sometimes like pencil cells can be seen, so anisocytosis can be seen. But in this patient's peripheral smear, you will be able to see spherocytes. Now, how do spherocytes look like? That also I'll sketch before you, but I just want to bring to your attention that if you're gonna read spherocytes in a peripheral smear, then you always have to think in terms of autoimmune hemolytic anemia. Don't answer SLE, because autoimmune hemolytic anemia again can be seen in multiple conditions. And how would you pick up like it is a spherocyte? Spherocytes will always be having like a smaller size as compared to routine RBC. You can see all RBCs tend to have a central pallor. So every time you see a peripheral slide, you will be able to notice central pallor in the RBC, but then the one that I've shown is lacking a central pallor and is smaller than normal also. So the message is spherocytes. If it was like a pediatrics discussion, I would have said hereditary spherocytosis is a condition where spherocytes are present. But these RBCs that I have currently shown before you, which are lacking a central pallor, are called as spherocytes. This would help you in image-based questions also. No? Like they can give you a peripheral smear slide and spherocytes would be present. How do you know it's spherocytes? They're shorter than RBCs and they would be lacking a central pallor and they'll be uniformly pink in color. So the message is autoimmune hemolytic anemia in this condition contributes to development of spherocytes. Coombs positive hemolytic anemia. The lady is saying, I'm turning pale, I'm taking iron supplements, and the iron supplements will not work in this condition because this is not an iron deficiency anemia. We need to give steroids for this. Over and above this, the immune system attacks white blood cells. It can attack platelets. So you could be having in petechiae developing in this patient. And now we come to, I've highlighted the alphabet, that is renal involvement in sonar. And this is like the bad news here because kidney involvement is occurring. So what is the test that we should be doing for diagnosis of renal involvement is that we can take a urine spot sample. And in the spot sample, we will check for urinary protein creatinine ratio. It is UPCR. Urinary protein creatinine ratio in a normal person would be less than 0.2. But if it turns out to be more than 0.5, it indicates that the damage to the kidney has already started. UPCR stands for urinary protein creatinine ratio. I'll just jot down the words here, though it is like a simple thing that PCR is to be followed here. That PCR word can cause error of judgment. Obviously, we are not talking about a polymerase chain reaction here. So it is a urinary protein creatinine ratio and it will require a spot sample for detection. Then we can check for presence of RBC casts because there is bound to be hematuria since the basement membrane of the kidney will also be affected. There's a vasculitis component also occurring. So hematuria, and the biopsy of this patient is a must for diagnosis. In fact, the biopsy findings of this condition are the ones which are like the one of the extensively asked aspects. Like one, he can ask you regarding light microscopy findings. Then light microscopy findings would be answered as wire loop lesions. Sometimes he can ask you regarding electron microscopy findings. For electron microscopy, he can ask you regarding the grades of nephritis that could be present or the classes of nephritis can be present. So most of the time it is like class 3 and class 4, which is given maximum weightage. I'll show you that slide also where the types are mentioned, but at the moment class 3 and class 4 are given maximum weightage as far as the damage to the kidney is concerned. And then over and above, he can also ask you regarding a immunofluorescence finding. This immunofluorescence finding is what is called as a full house effect because the whole immune system is there. All class of antibodies are attacking the kidney. It's like a free for all where everybody, it's like a mob. I would say there's a mob attacking innocent bystanders, and therefore we call it a full house effect. The additional points to be remembered would be that because there's damage to the glomerulus, the GFR will become less. Less GFR will contribute to higher renal hypertension and then development of end-stage renal disease. The word end-stage renal disease has now been removed from medical literature. The term was used for when the GFR of the patient used to go less than 15 ml per minute. That's normal is 125 ml per minute. If GFR goes less than 15 ml per minute, we call it end-stage renal disease. Now this term has been removed from medical literature because it creates a lot of negative vibes in the mind of patients and relatives alike. End stage, right? So we remove that word. We call it renal failure, and therefore next time, every time you read this word, it looks very benign, na? But then renal failure means, that's the question of the paper, that renal failure is defined as, the answer would be given as what I just said, GFR less than 15 ml per minute. And because we know that these patients, they're going to deteriorate, because at value less than this, there's bound to be development of uremic features. And because I know that uremia will start occurring in the patient, so I need to intervene. That is, we have to plan a kidney transplantation for these patients, or if it's not possible, then hemodialysis would be done. Now, sometimes there can be integrated questions where, along with the lupus nephritis aspect that I mentioned, the thickened capillary loops are visible. That is why the word that I was using was wire loop lesions. Then immunological features after sonar will be covered here. The first one on the agenda is anti-nuclear antibody. I mean, this is a must-have criteria for diagnosis of this condition. Anti-nuclear antibody is the most sensitive test for diagnosis of this condition. And at this point, I want to say that anti-nuclear antibody is also positive in scleroderma. So just by reading the word anti-nuclear antibody, don't answer SLE. Check out the clinical profile, because clinical manifestations of systemic sclerosis will be different. Anti-nuclear antibody can be positive in some cases of mixed connective tissue disorder also, which is discussed subsequently in this video lecture series. So the message at the moment is, it is the most sensitive test. But then, like, just because ANA is given a question does not mean that it is of SLE. It could even be that of a question of scleroderma. Then we have an antibody by the name of antibody against double-stranded DNA. I mean, look at immune system is turning against DNA itself. So antibody against double-stranded DNA, this is like used to monitor the severity of the disease. Like when all autoimmune disorders will be having like waxing and waning course. So when the disease will become more severe, then the levels of this antibody will tend to rise. And subsequently, I'll mention like how they would be looking on immunofluorescence as well. Then is anti-Smith antibody. It is usually written as anti-SM antibody. This is one of the most specific tests for diagnosis of this condition. In fact, there are two specific tests for diagnosis. One is antibody against anti-Smith antibody, and second is antibody against double-stranded DNA. Now, because I said two things, what should you answer? Then for antibody against double-stranded DNA, he says that it is specific only when the titers are high. For high levels of the antibody, then it is specific. Otherwise, the specificity tends to go down. So we will select one where we can be, even at lower titers, be sure about like ruling out the false negatives. So if a question comes as like most specific test, then anti-Smith and double-stranded DNA, both are good answers. But first single best answer would be anti-Smith antibody. Then anti-phospholipid antibody in these patients is a big troublemaker, because in anti-phospholipid antibody, we will be talking about like lupus anticoagulant. And this lupus anticoagulant is the troublemaker because it can cause a placental infarction. This can cause bad obstetric history. There would be recurrent abortions. There can be intrauterine death in these patients. So, I mean, lupus anticoagulant, the name is anticoagulant. The name is anticoagulant, but it is not causing bleeding. Lupus anticoagulant is rather causing a clot formation. So, I'll be speaking about this even in catastrophic or even in antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome is like where you have bad obstetric history anyway present. You know that from your gynecology obstetric class. But then I will be talking about catastrophic antiphospholipid antibody syndrome as well as antiphospholipid antibody syndrome, which can be occurring with or without SLE. I mean, APS, antiphospholipid antibody syndrome, can occur without SLE also. If it occurs with SLE, we tend to call it secondary antiphospholipid antibody syndrome. The common thing between antiphospholipid antibody and the current interest lupus anticoagulant antibody in SLE is placental infarction. So that explains recurrent abortions, intrauterine death that can be occurring in these patients. Then an additional thing that needs to be remembered is that there can be a false positive VDRL or RPR test in this patient. When I say this false positive RPR, I mean, this is like a false positive VDRL in a woman who's from a very good background. She says, "Doctor, what are you talking? You tell me I have SLE." I said, no, ma'am, this antibody is cross-reacting with the VDRL kit, and that is why like RPR or VDRL kit will turn out to be positive in this patient. Then because the immune system is activated, so C3 levels will be low. C4 levels will be low, CH50 levels will be low. So complement system consumption will occur during the inflammatory process, and Coombs test report in this person will be positive. A lot of questions of SLE may say, which is not a feature, and even deliberately write it's like Coombs negative hemolytic anemia, whereas it's actually a Coombs positive hemolytic anemia. So at the moment, what I mentioned before you is immunological features for diagnosis of SLE. Prior to this, I was teaching you clinical domain or clinical features. Those clinical features were made to be practiced by you by the mnemonic sonar, where we spoke about like synovitis, then serositis, then skin involvement, then there was oral ulcers and nasal ulcers occurring, then there was a non-scarring alopecia, neuropsychiatric manifestations, then subsequently the case evolved into renal involvement and autoimmune hemolytic anemia. So those sonar is the clinical features. And subsequently, what I mentioned before you are the immunological features, which are the list of these antibodies. Now, why are we mentioning these names once again is because he says that total 4 features should be present. And out of the 4 features that are present, at least one clinical feature should be there. What I mean by at least one clinical is like patient could be having anemia only, or patient could be having only photosensitivity, and the 3 would be laboratory features present. Or it can be vice versa, that one lab test is positive like anti-nuclear antibody, but then the 3 clinical features can be present. Clinical can be like this lady is turning anemic and she says, I go out in the sunlight, I get a burn, that is photosensitivity. And then subsequently, she's also having chest pain because she's having this pleuritis or pericarditis present. So we need total 4 features. I mean, the algorithm for diagnosis of SLE according to SLICC, this is SLICC that is being discussed, that at least 4 features should be present for diagnosis of systemic lupus erythematosus. And among these 4 features, it can be either 1 clinical with 3 immunological, or it can be 3 immunological with 1 clinical. I'll repeat this once again. It can be 1 clinical with 3 immunological, or it could be like only 1 immunological and 3 clinical features. But ultimately 4 features should be satisfied to say that this is diagnosis of systemic lupus erythematosus. As far as the cause of mortality in these patients is concerned, the leading cause after 45 years of age is like exerted atherosclerosis. There's a bimodal mortality in this patient. After 45 years, exerted atherosclerosis. If he says what is the cause of death in the first decade of diagnosis, not the first decade of life that I'm talking about, this is what I'm talking about is with respect to the first decade of diagnosis, then it is kidney involvement in infection. That infection component is due to 2 reasons. One, I told you, antibodies are attacking self lymphocytes, so lymphopenia is present. That is one explanation. And second is that patient would be put on steroids also, so further the immunity will become less. So a combination of the therapeutic agents that we are using and the immune system turning against self white blood cells is the reason for the infection component occurring in this patient. And because nephritis is one of the leading killers, that is why aggressive treatment needs to be given for, especially for class 3, class 4 and class 5. We do not give treatment in class 6 because then the damage is already occurred, then we go for transplantation. And in class 1 and 2, we monitor for like the further progression of the disease. If he says, when do we give aggressive treatment in the form of steroids for these patients, then we need to remember FDM. Like we open a FD for maximum gains, right? So FD for maximum gains. F is focal lupus nephritis. FLN, focal lupus nephritis, then is diffuse lupus nephritis, and then is membranous lupus nephritis. Normally, I write LN for lymphadenopathy, but today I'm describing it for lupus nephritis. I'll say that once again. We open a FD for maximal gains. So it is like focal, then is diffuse, then is membranous lupus nephritis. Normally, we read about like focal segmental glomerulosclerosis, membranous glomerulopathy. Today, we talk about membranous lupus nephritis. These are 3 classes, important ones, where aggressive treatment need to be given. And what is the aggressive treatment? One will be using is a calcineurin inhibitor, that is by the name of tacrolimus, and the second one that we use is mycophenolate. Obviously we can use steroids, but we'll go like all guns blazing. We'll be going more aggressive. That is because in this patient, ultimately, like if I don't turn on the aggression at this point of time, there is a possibility of like renal failure, and that would necessitate a kidney transplantation or a dialysis in this patient. That is for class 3, 4 and 5. Like class 6, the damage is already done. I mean, normally the thought process is that we should give maximum treatment in class 6. He says by that time it's a burnt out kidney, it's damaged kidney. So you need to intervene earlier. If the damage is like we say, there is no point of crying over spilled milk. In the same spirit, I'm saying like there is no point कि भाई अब कोई पढ़ा ही नहीं तो फिर तो एग्जाम कैसे कोई क्लियर कर लेगा, right? But the point is like if we are going to take action in advance, then we'll be able to pull through and sail through. Next is ULAR ACR criteria, where the entry level criteria is what I've already told you. Anti-nuclear antibody is more than 1 by 80 on Hep2. Along with this, there is bound to be some additive features. Those additive features are clinical domains and immunological criteria. The clinical domains are like constitutional, hematological, neuropsychiatric. You don't need to remember them. What you need to remember for the exam is what I already told you, the sonar mnemonic, and then subsequently the immunological antibodies that I spoke about. This is only for completion because this is an online calculator. Like patient is having neuropsychiatric manifestations. So they could be psychosis also, there could be seizure also. Now which among the two should, like I'll not do 5 plus 3 is 8. Whichever is the highest scoring, whatever is the scoring item, highest scoring item from the each domain is counted. So like patient of SLE, when she came to me, she had seizures also. And then she has been to a psychiatrist also because of a psychosis episode. She had delirium episode. So like they could be all the 3 manifestations present, but in the scoring part, we will be taking only one from a particular domain. Similarly, like if there's going to be hematological feature, then there can be lymphopenia also, thrombocytopenia contributing to petechiae and autoimmune hemolytic anemia, but we will be selecting only autoimmune hemolytic anemia. So one with maximum marks are selected. And similarly on the right hand side, you can see antibodies that are having a high index of like increasing our diagnostic yield are anti-double stranded DNA antibody or anti-Smith antibody, which are SLE specific antibodies. There are total of 3 immunological domains here. Here the word is not immunological criteria. It is immunological domains that I'm talking about. Anti-phospholipid antibodies, complement and SLE specific antibodies. Then is the clinical domains, which are like a total of 7. The remaining 4 are currently on the slide. Musculoskeletal. I told you musculoskeletal is like the commonest involvement in SLE, but check out the numbers here for renal biopsy findings of class 3 or class 4 lupus nephritis. That is where maximum score is coming. I mean, if this alone is present, no, that is a diagnosis of SLE. If we are able to demonstrate on kidney biopsy that there is a class 3 or a class 4 lupus nephritis, diagnosis is already made. You don't need to do anything else. So each of these parameters, like I said, there's a structured algorithm that is available. And the one that I've shown, the latest one is like ULAR ACR criteria. The older one is SLICC criterion, because both are given in the exam. Therefore, both at least the names of the criteria to be remembered. And as far as the clinical features are concerned, they are same only. No? It's only that they have been presented in a different way. Here also there is pericarditis, which is being considered for us or pericardial effusion that could be occurring as a complication of pericarditis. So it's like the same manifestation, the same set of manifestations, but presented in a different way. It's just 2 different names and the sonar mnemonic, which I think would make things easier for you. Now at this junction, even if you are tired, this is a repetition, but we are doing it because this is the main reason why the topic of SLE is asked in the exam. Most questions would revolve around antibodies only. So let's just do this once again. Anti-nuclear antibody has been told to you as answer to 3 MCQs. One, I have told you that this is an entry level criteria. I'll repeat this once again. When you were focusing on the word ACR or ULAR criteria for diagnosis, the first thing I marked was anti-nuclear antibody present. So this is an entry level criteria. That's like one of the statements that I said. Another one that I made was this is the most sensitive test for diagnosis of SLE. Sensitive is the one which will increase the diagnostic yield because it will pick up those true positives, or like I can say any test that is sensitive enough is also called as a screening test. So total of 3 times is where anti-nuclear antibody is to be answered. As far as double-stranded DNA is concerned, your answer would be that this is a highly specific antibody, but the rider for this is that only high titers are specific. That's one statement to be remembered. High titers are specific. And along with this, like because we are having 2 antibodies for specificity, so why do we do this? The advantage of checking the values of double-stranded DNA is that it correlates with disease activity. I mean, all autoimmune disorders have a waxing and a waning course. Sometimes the disease will become more severe, sometimes will become less severe. So if I want to just check out whether my patient is improving with medication or is he having a flare up of the disease, I can do a double-stranded DNA. And the diagnosis anyway, like the specific test for confirmation would be anti-Smith antibody. So initially for diagnosis, we'll be doing all the 3 sets of in autoimmune panel, all of them are done. But for academic reasons, they'll pick them up one by one and ask you like entry level criteria or the antibody which is like used for confirmation. That is why like I wrote, it's like the confirmatory antibody or is the most specific test for diagnosis. Then comes a name which I have not spoken earlier but is coming up now, that is anti-C1q antibody. This is seen in only more than 60% of the cases, so it's not so common as the previous antibodies. But still is asked because one, it is like less common, and second, it will help you decide the severity of lupus nephritis. Now mark my words there. Previously I was saying severity of lupus is decided on the basis of like double-stranded DNA because disease activity is worsening, so the severity will be worsening. But this time the question will say severity of lupus nephritis. So there are two different questions that I've handled. One is severity of lupus, that's double-stranded DNA. If we say severity of lupus nephritis, then it is anti-C1q antibody. Now comes the role of that Rulanevali antibody. There are two reasons why this antibody is asked, and the data in the green that I'm writing is like a must know for you guys. Anti-Ru antibody will cause development of photosensitivity manifestations, but over and above this, this antibody can also cross the placenta and can attack the fetus. And you're like, what, sir? You are saying autoimmunity will attack fetus or the lady? I mean, autoimmune disorder is supposed to attack the lady. No, it is attacking the fetus. Yes. This antibody, anti-Ro, is immunoglobulin G class. So it can have a transplacental spread, and because of this transplacental spread, it can go from the body of the mother to the fetus and can contribute to development of neonatal lupus. What I mean by the word neonatal lupus is that the antibody will attack the heart of this developing fetus. And when it attacks the heart where it is attacking, it is damaging the conduction system. The AV node of the fetus would be destroyed. Now SA node will control the atria, and the bundle of his will control the ventricles. That will cause the AV dissociation, or this manifestation of AV dissociation will be called as complete heart block. And at this moment, you might be wondering, like, are you serious? I mean, would they ask this? Yes, guys, they asked this in FMG exam. उसने पूछा कि complete heart block was seen in a baby born to lady with SLE. Which antibody is responsible? The name is anti-Ru antibody. So that's why I've highlighted this. देखो नीट पीजी में वो नेगेटिव मार्किंग होती है और एफएमजी में नेगेटिव मार्किंग नहीं होती, बस इतना ही डिफरेंस है. बाकी वो तो ठीक है, एफएमजी वाला थोड़ा इजी होता है पेपर, मतलब नॉट लाइक नीट पीजी तो बहुत हार्ड है, बट देन एट द सेम टाइम यू नो दैट द एडवांटेज इज द नेगेटिव मार्किंग नहीं है और एक में नेगेटिव मार्किंग प्रेजेंट है. तो यू हैव टू बी वेरी केयरफुल अबाउट यू नो स्पेशली व्हेन यू सिट फॉर नीट पीजी. तो यू नो द नेगेटिव्स हैव टू बी मिनिमाइज्ड. पॉजिटिव सबके बराबर बराबर होते हैं. इट इज लाइक द नेगेटिव्स हैव टू बी मिनिमाइज्ड एंड देन द एवी नोड ऑफ द पेशेंट कैन बी डैमेज्ड, सो देयरफॉर दे वुड बी लाइक अ ब्रैडिकार्डिया एंड मोस्ट ऑफ द टाइम दे कैन बी डेथ ऑफ दिस बेबी आफ्टर बर्थ. So anti-Ru antibody is like a must-know fact to be remembered. Now, next on the agenda is lupus anticoagulant, and the test that we're doing in this case is called as dilute Russell Viper venom time test. I mean, you are aware that Russell Viper will be contributing to hemotoxicity. It will cause to a patient to bleed to death. But in this patient, we are using Russell Viper venom and mixing it with the blood sample of the patient, and the end result is a development of thrombosis or a development of a clot. I mean, that is the peculiarity, that we're getting a clot formation, and that explains the placental infarctions that can occur in these patients. Next comes anti-histone antibodies. Well, anti-histone antibodies are associated with drug-induced lupus. I have just did an ink change to highlight the importance of this. Drug-induced lupus has a relatively better prognosis in a sense that in this, the brain involvement, like we don't get a lupus cerebritis, and we do not get a kidney involvement in this condition. So at least the kidneys are safe and at least the brain is safe. The mnemonic for the drugs is SHIP, that you know from pharmacology: sulfur drugs, hydralazine, isoniazid, and then procainamide. So I'll not write like all of them, but one that I can introduce is the one which he will say, what is the most common drug contributing to development of drug-induced lupus? The answer is procainamide. Last time I spoken about procainamide was for management of a patient who was having Wolff-Parkinson-White syndrome. Then comes anti-phospholipid antibody. Here we'll be doing two ELISA-based tests. One ELISA-based test is by the name of cardiolipin antibody, and the second one is beta-2 glycoprotein. And the patient is saying that, sir, your words are like Latin to me. Can you tell me, I mean, what is the importance of these antibody tests, ELISA-based tests that you're writing? So tell him, sir, these antibodies, like, ma'am, these antibodies are gonna ones which are gonna activate the intrinsic system of clotting. They're like, you know, in you and me, the intrinsic system of clotting is activated when there is some injury, when there is a clot formation occurring. But here, without any injury, there is like a intrinsic system of clotting getting activated and a clot formation in this patient. And that is why, like, a bad obstetric history is seen with respect to lupus anticoagulant and anti-phospholipid antibodies, two names mentioned here. Then the discussion becomes easier. Anti-erythrocyte antibody will cause a autoimmune hemolytic anemia. The peripheral smear finding of the same I've already explained to you, that is spherocytes. Then there can be antiplatelet antibodies. So don't be surprised if you get epistaxis in a patient, or menorrhagia, or petechiae and purpura developing in patients of SLE. That's because of the antibodies attacking self-platelets. Then we can have anti-neuronal antibodies that can explain the development of CNS lupus, which could be in the form of lupus cerebritis that can explain headache and seizures. And then is this anti-ribosomal P antibody, which has already been introduced for the neuropsychiatric manifestations of these patients. And as I've explained to you, there are two neuropsychiatric manifestations. One that I've explained is with respect to the depression part, and second is the psychosis component. The ones in green, I would say, are ones which you are never ever supposed to forget. I mean, all of them have to be remembered. All of them are super, super important. As I said, I mean, the antibody part is these two slides. Even if you say, sir, that second time when I listen to this video lecture, do I need to listen to the whole thing again? No. But the antibody part that I've spoken about is like a must-know fact, because most questions revolve around this. Now we'll focus on an important aspect of pregnancy and lupus, because anyway, a young lady in reproductive age group is suffering from the disease, so pregnancy would be on the way. So you will say, what drug would you use for active SLE in pregnancy? And here the first answer would be hydroxychloroquine. Hydroxychloroquine shot into prominence at the time of COVID. No, I mean, first time when people were reading hydroxychloroquine was, acha, COVID mein use ho raha hai. And then was rheumatoid arthritis ka triple therapy, triple therapy of rheumatoid arthritis. Subsequent video I've talked on hydroxychloroquine. And this is coming up once again in pregnancy. Why are we not focusing on steroids in pregnancies? Because of two reasons. One, the placental enzyme, that is 11-beta dehydrogenase, can deactivate the steroids. If I deactivate the steroids, then whatever medicine that I'm giving is a waste now, because that will not be able to control the worsening of SLE in pregnancy if it is occurring. Like this lady had a flare of SLE features during a pregnancy. If I give her steroids and the steroids are going to be deactivated by the placental enzyme, then there is no benefit of giving the medicine. Second, in the first trimester, you see, first trimester, we don't even give paracetamol. We avoid, right? We tell a lady if she's in the first trimester that avoid all medicines, and then steroids should also be, because we want to minimize the fetal risk. So there are two reasons why we are not in these patients going super aggressive with respect to steroids in pregnancy. One is the deactivation of steroids by the placental enzymes, and second is the fetal risk posed by any medicine. And therefore, we first start with hydroxychloroquine, and if required, add steroids. Then is antiphospholipid antibody syndrome, that will be discussed subsequently as well. But because of this condition contributing to repeated placental infarctions, bad obstetric history, mainly like in antiphospholipid antibody syndrome, what is the problem is that the uterine artery and venous thrombosis can occur. I mean, the antibodies that are present in this, they can trigger a uterine artery and a venous thrombosis. And that is why I was saying the word placental infarction. And if the placental supply is gone, there is going to be either a fetal loss or they're going to be intrauterine death. So what can I prevent this from happening in the next pregnancy? She's already lost, she had 3 consecutive abortions. What I can do is start her on LDA, that is low dose aspirin. And along with that, we can give a low molecular weight heparin like enoxaparin in the first trimester. We don't give warfarin in the first trimester, as you know, because it is teratogenic. So the approach has to be followed. Like she already had a recurrent fetal wastage. So to prevent this recurrent, loss of fetus again, the next time she conceives, we'll put her on low dose aspirin, enoxaparin. And in some of these patients, they may be on this low dose aspirin lifelong. I mean, the patient is saying lifelong aspirin at 25 years of age, you're writing me aspirin, you want me to take lifelong. I'll tell her, ma'am, future you can have stroke. She can have a heart attack. Imagine a young lady can have a stroke or aspirin. I mean, that how nasty this disorder is, antiphospholipid antibody syndrome, where it said that the antibodies can cause the intrinsic system of clotting to go into automatic mode. And because the intrinsic system of clotting is going in an automatic mode, that will trigger clot formation. Now, coming to the treatment of SLE, we'll divide this into 2 parts. If the patient is not having any organ-threatening disease, then it is the lowest possible steroids that we should start the patient on. I mean, we need to downgrade the steroids to the lowest possible dose, which will cause manifestations of the disease to get suppressed. But in some cases, patient may, not come for a follow-up, and they might remain on higher dosage of steroids for long duration. That can cause a steroid toxicity. Toxicity can be in the form of hypertension, osteoporosis, development of elevated blood sugar, hirsutism, weight gain. So considering that, then the monoclonal antibodies can come to rescue rescue here, and what we can be using is belimumab. So for the non-life threatening part, it is steroids and belimumab. But if it is organ threatening, then we'll go more aggressive, and therefore we'll have to give higher dosages of steroids. And along with that, we'll use mycophenolate or cyclophosphamide, either of the two. But if he specifies lupus nephritis, that's what he will mostly ask to you, because general answer is steroids only for left as well as right hand side. So he'll ask you for lupus nephritis, where we are not using steroids, but we are using mycophenolate and tacrolimus, that is a calcineurin inhibitor. I've spoken about this earlier also, and I just want to remind you that where are we going to use all this firepower is mainly for class 3, 4 and 5. There is no rule of like starting this aggressive treatment in class 6, because that's a damaged kidney, and either in class 1 and 2, where we need to monitor the progression of the disease. And most of the time patients come to us in like when they are in either 3, 4 or 5, when substantial amount of kidney damage has occurred. And the presentation of lupus nephritis, would like to remind you once again, would be one, presence of hematuria. Along with this, even proteinuria would be present. I mentioned about UPCR, urinary protein creatinine ratio, more than 0.5. And in case the diagnosis is not made, then uremia features will occur. Now, what are uremia features? That I'll not go into at this moment, but just want to remind you that urea can irritate the stomach, so they can be vomiting. Urea can irritate diaphragm, so they can be hiccups. Urea can cross the blood-brain barrier, so encephalopathy can cross over into pericardium, can cause uremic pericarditis. So it is no big deal that at this point of time in lupus nephritis question, the examiner can go into the kidney section and can incorporate manifestations of like when the toxins in the body are accumulating. Now, as far as manifestations of the disease are concerned, the important ones that I want you to remember from this handout is, one is non-scarring alopecia, then is the serositis part. That was a 2x2 table. The least common lung involvement and the least common heart involvement is, lung involvement is shrinking lung syndrome, and the heart involvement is Libman-Sachs. And Libman-Sachs can also be present in antiphospholipid syndrome, that will be discussed subsequently. Then these patients can be having peripheral neuritis. Even Raynaud's phenomenon may be seen. I did not mention it in the SONAR criteria, but Raynaud's phenomenon can be seen in patients of SLE, but is more common in patients who are suffering from scleroderma. Then the main biggest killer in these patients is lupus nephritis, or we can have CNS manifestations. So the handout is just to tell you regarding the huge range of manifestations, and that is why a particular set of criteria have been used, and diagnosis can never be made unless and until antibody profile is available. Now here comes the capability of the examiner to mix up this information with that of pathology. Like specifically for drug-induced lupus, I spoke about anti-histone antibodies, and in anti-histone antibodies, you will notice that he can give you a slide where a homogeneous green appearance can be present. So lots of time, like we can revise the pathology part here as diffuse histone haze. I mean, that's a mnemonic that can help you remember. When I say histone, it's drug-induced lupus, and that diffuse haze tells us that this would be a homogeneous pattern. Then is the speckled pattern. Well, speckled pattern is for anti-Smith antibody, and this would also be seen with respect to anti-Rho antibody. Another name for anti-Rho antibody is anti-SSA. This is anti-Rho antibody. The other name is anti-SSA antibody. And anti-Rho antibody is seen in SLE, that is okay, but it is also read in as Sjogren and mixed connective tissue disorders. So speckled pattern is like for multiple disorders. It's not diagnostic of any one particular one. Then is the nucleolar one and the centromere one. This is one that you will become more comfortable in the subsequent part of this video series, especially the centromere part. You know, for the centromere part, though, like the image I have shown here is like the centromeres in the periphery of the nucleus are the ones that would be involved. But crest manifestations will be so characteristic. No, at this moment, it might be a little overwhelming for you to remember these 5, so I'm not making you remember them. I'll just say them verbally. Calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, telangiectasia. Those 5 manifestations would be given for a female patient, and then he'll give you a slide and he'll say which pattern is present. So the point is, CREST syndrome has CC. The alphabets to be remembered is anti-centromere antibodies are present. So I don't find people having problems with respect to CREST syndrome, that is 5 manifestations, or systemic sclerosis, which is having more manifestations where there is a nucleolar pattern that is present. And these two will become much more clear to you when you progress subsequently in the video lecture series. But for this one, the current on interest, it is three names to be remembered: homogeneous, speckled, and rim. The rim pattern is specifically for that antibody against double-stranded DNA that is in the periphery. That would be like a rim in the periphery of the nucleus that will be noticed. So three patterns at this moment that I would request you to remember are homogeneous pattern, speckled pattern, and the rim pattern respectively, for like the rim pattern especially for the double-stranded DNA antibody that is seen in patients of SLE. That's, like I told you, this antibody is specific but only with respect to high titers, and we use it. Why do we do this test? Is mainly to confirm the diagnosis is okay, that Anti-Smith has also done for us, but to monitor the progression of the disease. Then next up is antiphospholipid antibody syndrome. This can occur with or without SLE. If it occurs without SLE, we call it primary. If it occurs with SLE, we call it secondary. And sometimes it can be catastrophic, where more than 3 organs can be involved, like the brain and the heart and the kidneys can be involved. So then I'll say catastrophic. When to suspect antiphospholipid antibody syndrome? One of the best examples for this is a young lady. She had a stroke. 45 years of age, she had a stroke, and it was found that she is having a hypercoagulable state. When you listen to my discussion of small vessel stroke, or when you listen about stroke per se, I've spoken about antiphospholipid syndrome as a hypercoagulable state contributing to stroke. Then can be, if you listen to the discussion on liver for Budd-Chiari syndrome, or if you listen for pulmonary thromboembolism. In both of them, when I have spoken about regarding hypercoagulable states, antiphospholipid antibody syndrome has already been there. So what I mean by thrombosis is they can be like DVT and then develop endopulmonary embolism, or the person can develop Budd-Chiari syndrome, which is thrombosis of hepatic veins, or the traditional thing, repeated pregnancy loss that I was saying. And in these patients, it is antibodies causing damage to endothelial cells, activating the clotting cycle. Well, what is the pregnancy morbidity? Pregnancy morbidity can be any of the three. You would have read this in your, even the gynecologist, obstetrician would have spoken about it. One can be, everything was going fine, doctor, and then I could not feel my baby moving. And I'm like, what? And she says, yeah, doctor, everything was fine. And 34 weeks, I could not feel my baby moving. It was a weekend. So I called up the gynac. She said, okay, come on Monday. And when I went on Monday, they just told me rudely, baby's dead. And they did not give an explanation. And she's asking you, sir, why did this happen? That like she was a unexplained death of a fetus. This is like, the death could be occurring anytime after 10 weeks or even in the later part of the pregnancy. Or she might have had preeclampsia or eclampsia, pregnancy-induced hypertension, or she would have had consecutive abortions. So pregnancy morbidity would be present, and that's why I can use the word obstetric antiphospholipid antibody syndrome. Profile here would be unexplained death on that's an important thing. Morphologically normal fetus. See, because what is trying to rule out is congenital malformations. No, anencephaly, myelomeningocele, none of them are present in the kid. And any of the three situations, if it is present, recurrent spontaneous abortions, death of a fetus beyond 10 weeks, or a preterm baby at less than 34 weeks with preeclampsia or eclampsia, and maybe if it was not detected, there could be IUD also. Intrauterine death is a possibility. So therefore, the lab criteria for diagnosis of this would be to run anticardiolipin antibody, that is a ELISA, and another one is anti-beta-2 glycoprotein. And what these antibodies do is that they trigger the intrinsic system of clotting to go into automatic mode. Now, as far as point number 1 is concerned, lupus anticoagulant, for this one, like I spoke about 3 lab criteria, especially about lupus anticoagulant, there are more details to be remembered. What do you mean by the word lupus anticoagulant testing? Is one that anti-APTT will be elevated, because I said the intrinsic system of the clotting is going into automatic mode. Prothrombin time is for extrinsic system and APTT is for intrinsic system. So APTT will increase. Then Collin clotting time and dilute Russell venom Wine test is the test that we use. That's an important name to be remembered. Dilute, I'll just write the name once again, Russell Viper venom time test is used for, that will be a simple one-liner. Dilute Russell Viper venom time test is used to assess which of the following. The answer is lupus anticoagulant presence, and this lupus anticoagulant is the troublemaker, in a sense that a combination of this lupus anticoagulant with these antibodies causes the intrinsic system of clotting to go into an automatic mode. Let us now focus on the diagnostic criteria for antiphospholipid syndrome. In earlier times, the diagnostic criteria was that at least one of the laboratory features should be present, like ELISA, anticardiolipin, or beta-2-glycoprotein, or lupus anticoagulant, or at least one clinical feature that could be in the form of vascular thrombosis or pregnancy morbidity. So if any one of the two were present, and the test had to be done at least twice, 12 weeks apart, for diagnosis of antiphospholipid antibody syndrome according to the Sydney criteria. But according to the 2023 update, what he says is one positive APL. What I mean by one positive APL test is that it can be any of the following positive, either lupus anticoagulant with that APTT and colon clotting time and DRVVT test, or it can be ELISA for cardiolipin or beta-2-glycoprotein, any one positive in the previous 3 years. Earlier, there was nothing like years. It was 2 tests positive in a span of 12 weeks. Now it says any one test positive in previous 3 years. And the clinical domains earlier were 2, vascular and pregnancy. Now is made it more extensive. Macrovascular, microvascular. What I mean by, person having macrovascular could be that the person could be ending up with the myocardial infarction, or microvascular can be like they can be development or digital ulcers, like small blood vessels thrombosis can be occurring. So that can be digital ulcers on the tip of the fingers or the toes in these patients, or they could be livedo reticularis, or they can be thrombotic microangiopathy that could be explained due to microvascular thrombosis. Obstetric part, I've already spoken about 3 points, that there's a possibility of fetal loss or recurrent abortions that are occurring. The cardiac valve disease is again a new entry here. This was never a part of the discussion. Libman-Sachs endocarditis. Earlier I told you Libman-Sachs endocarditis is a feature seen in SLE, but now I'm telling you Libman-Sachs endocarditis having sterile vegetations on the heart valves with special involvement of the mitral valve can be seen in both SLE as well as patients of antiphospholipid antibody syndrome. So the clinical domain has expanded to involve, like the words are microvascular, obstetric, cardiac valve disease, hematoneurological manifestations that could be in the development of stroke. That is, I was saying now that a lady with antiphospholipid antibody syndrome will be required to be on low dose aspirin, maybe on a lifelong basis subsequently. But with respect to pregnancy, if she's want to conceive next time, we'll put her on low dose aspirin with enoxaparin. I would suggest you to listen to antiphospholipid antibody syndrome from your obstetrics discussion as well. These are like the manifestations that can be occurring in this disorder. And I just wanted to bring to your attention livedo reticularis, which is like a fishnet appearance on the extremities of this patient. Livedo reticularis or a fishnet appearance can be seen in following disorders. It can be seen in SLE and antiphospholipid antibody syndrome, 2 of the topics of interest. We read about this even in literature of polyarthritis nodosa that is discussed subsequently, and even cryoglobulinemia that can be a complication seen with hepatotrophic viruses. So 4 causes. SAPC to be remembered, that is SLE, antiphospholipid antibody, polyarthritis nodosa, and cryoglobulinemia, which causes this fishnet appearance of the blood vessels on the skin, and that's like a small vessel involvement occurring with all of these disorders. Let us now attempt a question on the topic. Like, this young lady has been diagnosed with SLE and she's being tested for various antibodies, and he says which of the following specific antibodies statement is incorrect. The word is incorrect. Okay, I was expecting it to be correct. It is incorrect. Anti-Smith antibody is highly specific. That's a decent statement. Anti-Rho antibody is associated with photosensitivity and causes heart block in the fetus. Okay. And double-stranded DNA correlates to disease activity. That's okay. Decreases the risk of no. Anti-lupus anticoagulant the word lupus anticoagulant is related to, like I said, an obstetric event or subsequently the clinical events that I spoke about, which can cause a neurological involvement or can cause a livedo reticularis or can contribute to digital ulcers. So this is option number D here. The nephritis part was anti-C1q antibodies. So this discussion, guys, is all about antibodies. And at this juncture, I can say that irrespective of whichever stage of your life you are, whichever year you are in, whichever college you are in, it could be the topmost one, it could be a private college, it could be abroad. Time is something that is common with all of us. So, it does not matter where you are at the moment and how your career graph is going. You might be at the top of the league, right? Or you may be just average, or you might be just struggling to just stay afloat. But the time that you have from now till the exam is the key thing that will decide your future career. So if you utilize your time effectively to listen to the aspects that I've discussed in this video or in the subsequent videos or the previous units, then you are doing the right thing. You just need to keep the focus on, and you would be on your way to glory. So just utilize your time effectively, guys, from today and onwards. That is all that matters. Whatever has happened in the past, if you are top of the game, I'm really happy for you. If you're average, like, okay, not a problem, right? But then if you are like just saying that I'm struggling to stay afloat, it happens. Some days you're gonna be like, okay, oh man, so much to study. Some days you're gonna be, okay, I've learned this, I know this, I got this. So it's just like over a period of time, you need to keep yourself pumped up, and then you would be able to overcome and surmount all these obstacles. Thank you so much.